everyone. Welcome to Empowering Exceptional Minds, the podcast diving into neurodiversity through real conversations with parents, individuals, and professionals on challenges, strengths, and unique experiences. I'm your host, Maayan Glaser-Koren, an educational therapist, ADHD educator, and ASD specialist. At Educational Therapy LLC, my private practice, we support kids and adults with executive function and learning differences toward confidence and independence. This podcast is a collaboration with Wiz Therapy, connecting individuals to providers and streamlining services for neurodiverse communities. Our goal is to share strategies, stories, and insights to empower families, educators, and professionals. Before we begin, a quick disclaimer. The views and opinions expressed by our guests are their own and do not necessarily reflect those of this podcast or Wiz Therapy. The conversations here are for information and empowerment, not a substitute for professional or medical advice. And most importantly, if you are experiencing a mental health emergency, please dial 911 immediately, or you can text 741-741 to reach the crisis text line in the US for support. Hi, everybody. Welcome again to Empowering Exceptional Minds. I am so happy because I know this person for a while, and I'm so happy that I'm like, this is a surprise, people. I'm so happy he agreed to do the podcast with me. Norman Melancon, thank you so much for being here today. I'm going to ask you to introduce yourself and tell us your story and kind of what you do, how you do it. And again, thank you so much for doing this podcast, because I think that this episode is going to be extremely beneficial for many people.
Yeah, thank you so much for having me. I feel special just for being invited, so I appreciate that. And so I'm a board certified psychiatrist, and I currently have a private practice in San Jose, Campbell, Silicon Valley area. And I also teach. So I teach in a family medicine residency program in primary care. So if people aren't as familiar with medical training, after college, you go to medical school and then you go to residency, and that's when you pick your kind of area of specialization. And so I'm involved in a primary care residency, family medicine, and I do their mental health curriculum development education, and I also supervise in the primary care clinic. So I kind of have a dual practice where I kind of do my own thing in private practice, a little bit of therapy, a lot of medication and medical management. And I also teach in a community setting in Santa Cruz, California.
Wow. So what made you become a psychiatrist? Was there a
Yeah.
moment in your life that you're like, this is what I'm going to do?
Yeah, it's funny because one of my patients asked me recently this week, and I hadn't reflected on it in a little while about where it actually started. Um, but as a kid, I was always very interested in science. I had, you know, rockets, and I watched nature documentaries, and uh, I dreamed about, being like a scuba diver and like saving the coral reefs and such. But as I kind of developed and went to high school, there was a clinical program at my school
Hmm.
where you could actually one year you could be a CNA, so a certified nurse assistant. I think that's what it stands for. Or you could be an EMT,
Uh-huh.
paramedic. You could like, well, you can be a paramedic, but you could like start the process of being a paramedic. And so I did the year. I played football through high school and college as well, American football. So I could only do the CNA program. And so I did that just to kind of explore whether or not being in some sort of healing industry would be a fit for me. Um, and so for that year, I worked in a nursing home, actually. So I um, did manicures and pedicures. I gave people showers. I brushed people's teeth. I put on makeup. I did bed baths, And there was such a range. There were younger people with really severe neurological disease there. There were older people. And, being a teenager there, taking care of another adult, I think really shaped my um, perspective and personality. And uh, it really felt resonant with showing up and doing a good job and being appreciated for vulnerable people. And so that's kind of when I decided to go ahead and pursue medicine or just pursue a healthcare um, healing job. And because I'm a little bit overachieving, I was like, I'm gonna do the best that I can do. And so yeah, I went to a college. I worked for 2 years and then went to medical school. And I went to medical school with the idea of becoming a surgeon or a
Hmm.
cardiologist or something procedural. Mental health actually wasn't on my radar at all. Um, and just in the process of medical education and being in the hospital and rotating around, I realized in the fields that I thought I was interested in, which tend to be a little bit more procedural, a little bit more intense, I was also considering ICU or intensive care medicine, um, that the relationship with the patient primary, wasn't very primary, at least in the modern medicine or academic system. And psychiatry was like a strange, different reality of medicine where the relationship with the patient, even in the hospital in a short-term setting, was part of the intervention or part of the healing process. It was necessary to have a relationship in order to facilitate treatment or prescribing, especially with people that have really severe mental health conditions. And something about that just felt really natural for me and resonant for me, and something that I could see myself doing for a lifelong career. Um, and so yeah, that's how that went down. And I went and did my a psychiatry residency at UCLA, and then moved here to the Bay Area after.
Yeah, your story is fascinating. I'm just like so in awe right now. Like being that young, in high school, when most of the people that I know, including my children, have no idea what they want to do when they go, right? So
Mm,
I think this is like having a purpose and you just kind of figure it out as you go along.
mm,
That's the missing piece, especially when it comes to relationship and healing. And I mean, the body and the mind are connected. We cannot separate it.
mm,
So
mm,
I'm guessing that I don't know. I'm not a doctor. I was never, I was on the amount of time I was in a hospital because of, medical reasons was because, I needed, attention, but
mm,
it was never, um, all these things like getting into, like you said, ICU to like emergency room to those things, is traumatic.
mm, mm,
I
mm,
mean, it's taking you out from the control of your own body, right?
mm.
So I completely understand. I was thinking about it while you were like talking about it, like, oh my gosh, that makes so much sense. And
Yeah.
it's not something that we see on, television and all those like medical dramas that I am addicted to. People, I am completely addicted to medical traumas, medical shows. Sorry, no traumas. I have a new. I like the pit now. Now I
Oh
don't.
yeah.
There is only
Yeah.
one psychiatrist. There's some psychiatry there. But this is something that I will watch. Right, I was a ER person and doc and you name it. I watch them all.
Yeah, yeah, I've really enjoyed The Pit as well. It was actually hard to watch for me in the first few episodes because it was so realistic that I felt like I was back in
The pit.
medical training. Yeah.
Yeah.
Um, but in a way, like I feel like it does a good job of demonstrating the like the high stakes decisions that happens like constantly throughout the day, and like the lack of personal space or peaceful time or rejuvenation, and also just like all of the system issues that happen for every single person. It just kind of took me back, and it was like a little bit flooding
Oh, wow.
in
So
the
that means
first.
it's a good show.
Yeah, yeah, yeah. I think so. I think so. I think so.
Okay,
Uh,
although we can talk about TV,
yeah, yeah, yeah.
which
Sure,
is
sure.
one
Yeah,
of my favorite
yeah,
stuff I love to do. I do have some questions for you
yeah, yeah.
with your extreme specialization in um, PTSDs and OCD and different kinds of mental health uh, challenges like depression, bipolar disorders. So I feel like, I'm also working with a lot of ADHD. That's like where, my passion is with ADHD and ASD and trauma and OCD and general anxiety disorders. So what I notice when I talk with families is that, or with individuals that are adults, that there is a lot of fear and there is a lot of like misinformation because we live on TikTok generation,
Hmm.
and there is a lot of stigma
Hmm.
about ADHD medication. Um, so, what are the most common myths that you encounter from patients and families? For me, I can tell you that I hear stuff like, it's going to change the way my child is. Like, they're, and this is not from a judgment place. I just want to make sure that people understand that we are not here to judge decisions at all.
Hmm.
We are here to dissolve stigmas and the misinformation that are being fed years and years since Ritalin was introduced, and and also have this understanding that sometimes these individuals will choose substance abuse if they don't get the medication.
Hmm.
So there is so much things to unpack here. And there are cases when somebody maybe has Tourette syndrome and they cannot take stimulants. So we want to make sure that, or a kid who is underweight, right? And then we have that side effect. So if you can just share a little bit of what you see with misinformation and what you come across and how you help parents understand before dismissing or delaying the medication.
Yeah, yeah, of course. Um, and I'll be curious to see if the things I mentioned show up for you as well, because I
Mm-hmm.
also know I think that my perspective is slightly biased because usually when people reach me, they've like come far enough along that they're willing to consider it. But yeah, I think the main things that I hear about are addiction risk, personality changes, and then like short-term side effects, long-term side effects. Um, so so yeah, parents or people who take whether it's the kids or adults that take medication, it's common to have a concern about addiction because these medications are pretty easily abused or misused, especially in the teenage or college environment. Um, but what I try to counsel is that taking stimulant medications is not like a gateway drug into addiction, right? Like even in evidence-based medicine, there's studies like in the 2023, the Journal of American Medical Association did a long-term study um, in children looking 16 years of taking stimulant prescriptions into adulthood. And they were mostly looking at the risk of addiction compared to other children who did not take stimulants and their risk of addiction, and basically found there was no association between long-term stimulant use and predisposition to substance use or addiction. So uh, the data kind of supports intuition that stimulants for people who have ADHD, right? We're talking about specifically for indications. There's not an increased risk of substance use and addiction. Um, but there is a potential for misuse of the medication. So that's kind of why we have to be a little bit more individual, like know the child and know the adult well, know the environment. Sometimes I recommend having a lock safe, especially for college students who live in dorms, because I'm not as worried about my patient misusing it, but I'm worried about maybe someone finding it and stealing it or so I sometimes recommend a safe in that for that reason. And I just counsel them that it's not safe to misuse it, right? It's not safe to use the medication to stay up all night, to pull an all-nighter. It's not safe to take the medications and mix it with other medication, other like drugs when going to a concert or a festival. Um, and I find that most of the time people who have this uh, pretty significant disorder, they don't want to be in a situation where their behavior compromises their ability to get the medication. Um, so for people that don't have a prior substance use or addiction pattern, I don't really worry too much about it. And I think that helps parents adjust with a little bit of data and a little bit of personal experience. For personality changes, I try to acknowledge what's actually real and what's not. So I think I hear the term like worrying about becoming a zombie often.
Yeah.
Um, and that I'm like, nah, don't worry about like that's not. It's like you don't want your child to become a zombie. You don't want to become a zombie. I don't want anyone to be a zombie. Like that is not. I consider that a poor job done. And I'm not out here trying to do a poor job. Um, but what it is not universal, but common art is irritability and maybe some mood changes,
Mhm.
especially because the medications are active only for a certain amount of time. That might be 2 to 3 hours, it might be 8 to 10 hours, but there's an experience kind of each day of being experiencing the medication being active and then experiencing the medication being off. And so that can kind of lead to some mood or behavioral changes. These are like always reversible. So I tell people if something doesn't feel right or something changes, we'll just make an adjustment. It's not nothing permanent is going to happen from an unexpected side effect. Um, so that can help as well. Um, and I just try to engage with them that I'm on the same page. I don't want anyone feeling awful. Like the point of me seeing you and helping to address this issue is so that you can like have a higher quality and a more joyful life, more successful and productive life. If that's not happening, like I'm with you. We can adjust the dose, we can change the medication. Um, there's a whole pharmacology world of medications with ADHD, stimulants, non-stimulants. And there's some newer things too that I use as well. So uh, I have a cornucopia of options. If people have some patience, 95% of the time I can find something that works with their natural physiology, biology. And that usually helps assuage. Um, and then the last thing is like the actual side effects, long term and short term. So it's important for people to be aware of potential for decreased appetite, right? So we can mitigate that by uh, either taking a long-acting medication right after breakfast, so do a huge meal in the morning, and then a big dinner at night. So when the medication's not as active, and that way you get your calorie needs done. And then lunch, it might be a snack. But if the appetite's not there, we've covered calories and nutrition in the morning and in the evening. Um, and then if things are really bad, then we just go to short acting. So we'll use a medication that only lasts 2 to 3 hours. So you'll have breakfast, you take your medication, it'll wear off by lunch. You have your meal, then you take your second dose of medication, it'll wear off by dinner. So we can, and also each medication has a slightly different risk of appetite suppression. So we can mitigate that just by making adjustments. Um, as well as another short-term common thing is insomnia or like difficulty
Mhm.
sleeping at night. So that's much more common with the long-acting medications. Each long-acting medication lasts for a different amount of time. So if someone's having sleep problems, I just change them to a medication that either is a long-acting but a short, so like maybe 4 to 6 hours instead of 8 to 10, or we use an instant release. They might be a slow metabolizer in their liver, and that instant release actually lasts them all day, and then they can sleep fine. So that's easy to address. Irritability and anxiety usually can be attenuated as well by changing the type of stimulant that we use. Instead of using more of an Adderall-derived derivative, we can use more of a Ritalin-derived derivative. And that usually can attenuate those irritability, anxiety, personality changes. Um, and then we just monitor for blood pressure and heart rate changes. The biggest long-term thing to keep in mind for children specifically is growth suppression.
Mhm.
So there is a little bit of a risk of stunted growth, usually half an inch to maybe an inch, inch and a half, um, in children who take stimulants. And I haven't really noticed anyone that uh, has decided not to take medications for that risk, but that's just an important one to consent people to. Um, in the long term, it's mostly the cardiovascular effects. These medications are like some of the longest, most studied medications in psychiatry. So we have a lot of safety data. For the most part, there's not a huge concern with them long term. However, you do want to be on top of of monitoring blood pressure and heart rate changes. I've had some patients that'll take a medication and their blood pressure will go from 120 over 80 to 160 over
Ooh.
110. And that's not normal, but if that goes unmonitored over time, you would expect there to be long-term problems, right? So there is some data to say, especially over 5 years of cumulative stimulant use, that there can be an increased risk of heart disease, mostly from hypertension or high blood pressure and artery disease. In artery disease can be a result of high blood pressure because you can imagine if you have a pump that you're pushing water through and you have a normal kind of like smooth flow, but if you increase the pressure, the pressure in that tube of the water flowing through is going to be more severe and like damage the walls of the tube. Um, so I think that we feel like with good medical monitoring, we can attenuate some of those long-term effects. Um, but it is something just to be aware of. And I try to encourage my patients to take drug holidays, not take medications on the weekends if they can afford not to, based on their level of severity, not taking it on vacations. Um, and so that gives an opportunity for the physiology to kind of go back to baseline. So that's kind of how I talk about it in a medical sense. But the big picture is that the short-term side effects can be resolved just by making dose adjustments or type of medication adjustments. And the long-term risks aren't super severe, especially compared to the risks of not treating, which I think we might get to later.
Yeah, let's just talk about it right now. I mean, you answered my question because I wanted to ask you about vacation and weekends because I know some
Mm,
people who don't take it. So
mhm,
I'm happy to hear that it's okay and it's actually encouraged to
mhm,
stop. So let's talk about what happens if it's not being treated, right? If
mhm,
somebody also has, ADHD is almost never by itself.
mm.
It always comes with a friend calls anxiety. So I'm really interested to hear from you about those things as well.
Yeah, yeah. Yeah, I think maybe one of the other things I didn't mention is that I think patients and families worry about overdiagnosis or overprescribing of these
Mhm.
medications as well. Um, And what's interesting is that it's not, I think it's not necessarily a sense of overprescribing, but misprescribing.
Mm,
So patients that don't necessarily need the medication or have like a mild case get prescribed medications, but people with moderate and severe disease go missed. So there's like a 2021 study in one of the neuroscience journals that said for every one person that is receiving medication without a formal assessment and diagnosis, so maybe misprescribed, there's actually three patients with formal disease that are not getting medications and not getting benefit. So I worry less about overprescribing and just making sure that the people who need it are getting it. And so that's what's important because for the most part, stimulants are performance enhancing. So if you don't have neurodivergence, if you don't have ADHD, if you don't have maybe some off-label uses for narcolepsy or treatment resistant neurovegetative depression, like depression where you can't get out of bed, or geriatric depression, some of these issues. If you just have normal behavior, normal neurobiology, normal brain, and take it, you're probably still going to have some performance enhancement. So that's kind of why this is a little bit more of a complicated issue compared to like antidepressants. Like if you're not depressed, if you don't have an anxiety disorder, if you don't have OCD and you take Zoloft, you're not gonna like feel more happy. If that makes sense.
yes. And all of these is because the brain doesn't make those, right? So that's why.
It's kind of mm, more
For ADHD, isn't it about like the brain doesn't make enough dopamine, right?
It's more about the connections between different areas in the brain
Mm-hmm.
and how those connections interact with each other, with each other. So stimulants increase dopamine, they increase norepinephrine, they increase serotonin to a certain degree. Um, and that mechanism increases the the circuits and structure that are abnormally functioning. It's not necessarily like a dopamine deficiency, if that makes sense.
Yes, thank you for clarifying this because this is something I hear too. So I wanted to mimic
Mm-hmm.
what I've been
Hmm.
hearing. Um,
Yeah, yeah, it's more complicated.
it is very
But to
complicated.
your question about not treating, right?
Mm-hmm.
So oftentimes, and this comes up actually with many mental health disorders, right? Depression, especially for peripartum anxiety and mood disorders. Should I take medication when I'm pregnant? Should I take medication when I'm breastfeeding? Um, and I think it's easy. Should I take stimulants for ADHD? I think it's easy to look at the harms of and side effects of the medication, right? Because we can easily quantify it. When you Google it, it comes up, it's in your face. When you AI search it, whatever. Um, but what we don't look at as the negative side. What is the cost? What is the harm? What are the side effects of not treating? And for ADHD, we know it's pretty significant for people with moderate to severe illness. So, um, how much would you think that like the United States as a whole, loses in economic productivity and extra costs from people who have ADHD that's not managed? Like if you had to put a number on it.
I have no idea.
Mm. So I think the last study I read was somewhere to 100, mid 100 to $200 billion across the United States society is lost from um, um, undermanaged, poorly managed ADHD consequence, loss of productivity, unemployment, criminal incarceration, things that can be linked to that. So we know the cost of treating actually has a number per person. I think it's estimated maybe 15 to $20,000 a year. Um, and that comes from, right, poor performance in school, possible premature discontinuation of school, right, a longer school duration, a longer college duration, higher unemployment rates, higher criminal behavior and jail time, less financial success over time, debt, unintentional injuries, right, car accidents, bike accidents, people with ADHD, especially in the moderate severe side, have a premature mortality risk because of the chance of accidents. There's so many people that I've seen that come to me after they've gotten into multiple car accidents, after they've just being around in the home inattentive, cutting fingers when cooking, putting their phone in the freezer, driving off from the gas station with the gas nozzle still stuck in the car. Um, so we can actually put a cost on those behaviors. And so I also try to factor that in when we're talking about whether or not the benefit of medication um, to resolve this cost is worth um, the potential side effects of appetite, sleep, maybe long-term heart things if we don't monitor and manage well.
Yeah, for me, it will be like, car accidents, substance abuse, all these kind of things. This is what
Hmm.
something that will be, I would be scared, right? I
Hmm.
do, I want to, I'm sorry, I'm gonna put you on the spot with this.
Yeah,
Um,
please.
Multiple times, you mentioned ADHD is illness. Can I
Mm,
ask you
mm,
why that's like the terminology? Because from the way I see it, I see it's just the way of brain function differently.
mm,
Um,
mm, mm,
and
mm,
illness is something that needs a cure, right? Where
mm,
we're not
mm.
trying to cure people, we're just trying to support them.
Yeah, yeah, yeah. Yeah, I guess the if I said illness, the maybe the more proper term is disorder, but it's I think in the medical language doesn't necessarily suit the personal individual experience. And
Mhm.
so, because we have a system based on diagnosis, categorized by the medical language, if you're sick, right? If you have a heart issue, if you have a skin infection, we consider that illness disease. That's how it gets coded. That's how your insurance pays for it. That's how you get reimbursed. So it's just like an application of that language to mental health experiences that we then categorize, code, bill, so that the system still acknowledges the reality of it. Um, so it's interesting, kind of like being in psychiatry, where you're on both and you're catching me kind of like trying to walk both sides, right? One side where I need to medicalize it in order for you to get the prescription, in order for things to be covered, in order for you to be reimbursed, um, in order for studies to be done. But on the other side, the psychological side, the affirming side, we don't want to pathologize someone's experience or their neurobiological uniqueness. But if we don't translate that into quote unquote disease, illness, or disorder, um, then then we can't access the system which is designed in with that language. Does
Thank you
that
for
make sense?
clarifying. Yes,
Yeah,
I really
yeah.
appreciate for you for clarifying this. Um, I do want to ask you a question about also thank you for clarifying about the medication, the side effects, the long-term issues that we, see when we are not getting support. And not from a place of like scaring people, but really
Yeah,
through
yeah, yeah.
understanding both
Yeah.
sides.
There's
And
so
at the end
many
of the
people,
day,
right, that like they get medications, they get stable, and they're like, all right, I don't need to see a doctor anymore. And so they
mhm,
just get refills from primary care, maybe once, and they get seen once a year. They don't follow up on their blood pressures, and then 10 years later, So it's not to be scary, but just to be uh
Cautious.
yeah, 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 exactly.
Yeah, we want people to be cautious. I mean, I'm on meds. I'm not ashamed to say it.
Mm,
Um, and they changed my life.
mm,
Can we talk a
mm,
little bit about the comorbidity of ADHD and OCD? And I know OCD is one of your kind of expertise,
mm,
and um, they don't seem sometimes an obvious pair, but they actually core more than people realize.
mm,
So how common it is, and how difficult, or how do you tease it out? Is it the OCD? Is it ADHD?
mm,
So in a very quick, simple language,
mhm,
what is OCD? Because sometimes people think, and we had discussion like this in this podcast before, this just washing hands, but people need to understand OCD
mm.
is your thoughts are being stuck, right?
Yeah.
So if you can kind of talk a little bit about that, that would be great.
Yeah, yeah, yeah. I th the maybe the most concise way to think about OCD is there's an intrusive thought or image, right? So like it's not your control, you're not summoning it. Um, it just comes in, and then the response to that thought or image is a ritual or a behavior in order to decrease the distress from that thought or image. So the hand washing example would be the intrusive thought is my hands are contaminated or there are germs on me. The ritualistic behavior is to wash hands. Another example would be the intrusive thought is like, I didn't lock my car. The compulsive behavior is I need to go back and check the car. And so it becomes OCD when that cycle, that response ends up taking hour, 2 hours, 3 hours throughout the day, every day of the week in a way that leads to functional impairment or decreased ability to kind of have a high quality life. Um, so there's like so many, I think there's maybe 30 or 40 different ways that this can met, it could be somatic, it can be physical, it can be images of it can be more vile, harmful, intrusive thoughts. But the idea is that they're ego dystonic. So that's maybe another layer is that people don't are in distress about these thoughts, about these images. It's not that it gives them joy or like kind of increases desire to do them or it feels good or they yearn for it. So that's kind of how we distinguish some of the more uh, the thoughts that are a little bit more, what's the right way of saying it? Stigmatized or
Mhm.
inappropriate. Um, So yeah, basically a thought or image comes in. I do a certain behavior in order to feel good. It might be clearing my throat multiple times. It might be counting 1, 2, 3, 4, 5. Um, it might be avoidance, right? It might be I don't drive down this street because it's by a park, or I don't take the highway because the highway goes by. So yeah, that's the kind of domain.
So I'm just really interested because my colleague and I had a conversation about that
Mm,
with what is the procrastination piece with it ADHD and the OCD if they come together.
mm, mm.
How do we help and support when they are together?
Mm, mhm, mhm, mhm,
Because both, you said the word avoidance.
mhm,
We
mhm,
see that in both, like ADHD is task avoidance, but
mhm,
it can also be the OCD. So that's very
mm.
confusing. What is what?
Yeah, yeah, yeah. Most of the time, one of them is the bigger impairing issue. Um, so you can typically, there's enough domain difference that you can typically tease out whether or not someone has one or both. And then you can tease out the severity of each one. And then that's kind of how I prioritize which to treat to address the shared symptom. So Mm, so like if someone who has OCD, like, and that's the primary issue, it's not necessarily that their life is impaired because they are forgetting things, they're late, they're um can't stay on task. It's more that they spend so much time in their mind trying to manage their thoughts and so much time trying to alleviate the distress that they feel from these thoughts or images that they're exhausted. And that leads to avoidance and inattention and like withdrawal. And so we would start with a treatment plan to address that first, and then we would come back to the ADHD and see what was left that was maybe causing issues at work or in school, and vice versa. I've had people with ADHD that like leave their phone everywhere they go, their phone's off. They got Apple tags on everything. They got 70 post-it notes on the mirror. They've got a pair of shoes in the car, in the office,
Hmm.
in the gym. There's a pair of shoes everywhere because they might forget shoes. They wearing different socks. Those people, we might start with the ADHD and leave the hand washing, contamination, germ issues alone because they might be washing their hands for like an hour a day. But that's not what is leading them to have an impaired um, life experience at work or at school or at home.
I
Does that
see.
kind of make sense?
Yes, yes. And
Um,
I just wanted to kind of clarify that in most cases, OCD cannot be treated without medication and therapy.
OCD, that is another interesting difference between the two. OCD, the biggest effect size for OCD comes from therapy, specifically exposure response
Hmm.
therapy. So if someone has pretty significant OCD and they're not doing exposure therapy, the chance that they get better is low. Um, if they're on medications alone, there is a notable effect compared to no medications at all. But someone with OCD that just takes medications and does not do therapy is not going to do as well as someone who does therapy and doesn't take medications. Does that make
Thank you.
sense? So
Yes,
therapy is actually more effective than medications for OCD. Now, if you combine them, obviously you get the biggest effect.
yes. And that's true for
Medications plus
everything.
therapy.
That's true for every, same with ADHD, same with PTSD, same with, I know we didn't touch PTSD at all, and I'm so sorry.
Mm-hmm.
We do need to finish up. I'm more than
Yeah,
happy
yeah,
to
sure. Yeah,
have you
yeah,
come
yeah, for
here and
sure.
talk about
A
that
part
part.
two.
Yeah, that would be super cool. Um, is there anything you want to kind of share with our families that listen?
Mm.
What are the takeaway from our today's conversation that you want to kind of spread out there?
I think the biggest takeaway is just to make sure that um, is just to make sure to hold the cost of not treating. I don't want to convince or pressure anyone to take medications. I don't want to convince or pressure anyone to do therapy, but I do want people to, when they're looking up and seeing, oh, and finding reasons not to pursue treatment for themselves or for a family member, I want them to also look up and see what are the costs of not treating, of not doing therapy, of not getting executive function coaching, of not taking medications, and then weigh them against each other instead of weighing taking medications and side effects versus like not taking medications and not having side effects.
Oh my gosh, thank you so much.
Mm.
That was such an informative conversation. I really appreciate you being here.
Yeah, yeah. Thanks for the invitation.
Thank you for listening to this podcast. It was a fantastic episode. Don't forget to subscribe to our YouTube channel, follow us on Apple Podcast and on Spotify. Take care. Bye bye.